Try to stay with me. I'm going to be as brief as possible, simply because we are likely to keep seeing these things over and over and over again. Right now, I just want to tell you what history-taking stations are and how you recognize that a history-taking station is actually a history-taking station. You would take history as usual. So that would be the presenting complaint, either Odipara or Socrates, followed by your differential diagnosis, and then your general background health questions. And then you would use communication tools, and we'll go through those things. When you get to examinations, you would explain the examinations you need to do. And then you would even approach as though you would like to do the examinations. I'd like to examine you now. I'd like to check your general observations, Mrs. Smith. This will include your blood pressure, your oxygen levels, how fast you're breathing, and your temperature as well. I'd also like to do an examination of your chest, listen to your heart and lungs, and examine your tummy as well. Is that all right? Yes, that's all right. Okay, I'm going to be ready to do those things, but the examiner will either stop you by giving you clipboards or papers, or give you verbal findings. You can also know, because sometimes there's clipboards. And so you will then explain the findings to the patient and give a provisional diagnosis and any investigations. And we'll talk about those things later. But this is where I want to focus on the examinations. Nowadays, simple examinations may still be needed. You may still be required to be able to assess someone for the symptoms of polymyalgia rheumatica, or somebody presents to you with muscle aches and pains. You may have to ask them, can you please try to raise your hands above your shoulders quickly? Okay. Can you try to stand up without support? And then you need to be ready to support them. Parkinson's follow-up. You may need to check for the tremors. Somebody has a frozen shoulder. You may need to try and ask them to move their shoulder. Simple things can still come. So let's answer a couple of questions here. Khubayb Samdani is asking, does it waste time when they hand over the findings or investigations? Well, it doesn't waste time, because you already trained yourself to not waste time. Everything is designed to be done in 8 minutes in this exam. That means that when they're handing you the clipboard, take it, say thank you, read what's the findings, and then explain the findings. It is not wasting your time. It is giving you marks. Okay, and there's more to come, so please stay tuned. Again, thank you guys for joining our first day. We are going to be going through the general approaches, and then we're going to do some cardiology today as well. So, combined stations. What are they? Person, mannequin, person. That's what it is. Person, mannequin, person. You will take history from the mannequin, from the patient. You will then perform the relevant examination on the mannequin. There's only something that you need to know. If there's more than one examination that is necessary, if there's only one examination that is necessary on the mannequin, it doesn't mean you don't have to mention any other relevant examinations. So you could find that in the room there's a parectal examination, or that there is an abdominal mannequin, let's say. But I also know that when somebody comes to me with ascites, it could be due to multiple things, and I may need to do my observations. I need to check for pulmonary edema. I need to do a respiratory examination, as well as an abdominal examination, including shifting dullness. Maybe the findings for the respiratory and cardiovascular examinations will be given to me on a clipboard, but the findings of the abdominal mannequin examination, I need to find on my own. And then I may also ask to do a parectal examination to examine the prostate, and the examiner may give me findings of the other ones that are not mannequins. So just make sure you don't forget to do all relevant examinations. And when you see the mannequin, your practical skills, your examination skills are being tested, and that is why you will find them yourself without findings. But other examinations, they will give you findings. And so you then explain the findings back to your patient. You will then diagnose and manage appropriately. Another question from Khubayb. The question is, do we have to walk towards the examiner to pick up the findings, or the examiner is sitting near us? Khubayb, I don't want you to worry about that. If the examiner is far away, it's okay. Maybe the patient will hand you the findings. Okay, they are also very aware about these things. They will make it in a way that is suitable for the candidates. So I don't want you to worry about that. If you have to go and quickly grab the findings, quickly go and grab the findings. But I promise you, if the examiner is sitting far, it is going to be either a verbal findings given, fundoscopy is normal, for example, or the patient will hand you the findings because the patient is closer to you. So they will make life easy, not hard. They don't hate you. They just want to see you and assess you. For your talking mannequins, we use the A, B, C, D, E approach. And so I need you guys to know that time management here is very important. If in these kinds of scenarios, you don't do everything practically yourself, you will fail. It is not verbal. It is all practical. I can see that you're having a bit of shortness of breath. You're breathing really fast. Your oxygen levels are low. I'd like to give you some oxygen. I just want to ask you a couple of questions. Do you smoke? Have you ever been diagnosed with chronic obstructive pulmonary disease? Right. Then I'll give you 15 liters per minute high flow oxygen by a non-rebreathing bag. Give me a second. You need to go to the trolley. You need to take the NRB mask and you need to put it on the mannequin. The vitals are going to be attached. There will be heart sounds. There will be lung sounds. There will be pulses or absent pulses. If they need to give you acute limb ischemia, they will make it pale. They will make it pulseless. They will then make the patient speak to you from a speaker on top of you. And all that you need to do will be on the mannequin, and the mannequin is responding from a speaker on top of you, and it can hear you, and somebody on the other side is responding to you. Everything is practical. And so it takes a little bit of practice, and we do have a talking mannequin that you can practice on here as well. We do supervised classes. We do also workshops for all of those things. Procedure time. For the procedures, you may need to teach some procedures. You may need to do some procedures. One thing that you need to know is that it is designed for you to just do the procedure. The relevant history is going to be about being on blood thinners or, confirming identity, the usual things. I don't need to go too deep right now. We will have procedure day. I just need you to know that they will expect you to either teach a procedure or do a procedure. And so, you do need to know what is covered. Teaching scenarios again, informed consent teaching, urine dipstick teaching, subcutaneous teaching. This tests not only your ability to build rapport with a colleague, but positively influence your colleague. And yes, a lot of the time we ask, what are the data gathering marks? The data gathering marks for teaching is to actually ask them, what do you already know? Do you know this? Do you know that? Take it easy. You just need to engage them. Sometimes we forget that these are already medical students or student nurses. They have some knowledge. And if you don't allow them to tell you what they already know, you're going to miss the opportunity to teach them what they need exactly and not just teach them everything unnecessarily. Good. Prescription time. When we're talking about prescriptions, I want you to know that usually there are no patients in the room. There will be a prescription paper, there will be different color pens, and the latest BNFs are all going to be there. So I made a couple notes here. I said it's okay not to use the BNF and memorize the doses blindly, but that is because of one reason. It's divided into three usually. The main task, an antibiotic or methotrexate. This one requires you to open the BNF because you need to be a safe doctor. But then the additional auxiliary task of prescribing the patient's regular medication, such as amlodipine or statin, they already are very clear, and you don't need to open the BNF for them. You just prescribe them. And then usually there's a third area, which is catch the mistake. You have to maybe make sure that you catch the mistake that the consultant asked you to prescribe a medication that the patient is allergic to. And so what do you need to do? You need to prescribe the alternative. A good example is a patient with, let's say, community-acquired pneumonia. Community-acquired pneumonia, we treat with penicillin. However, if the patient is allergic to penicillin and allergic to azithromycin or a macrolide, the third option is something that you need to know, and you may need to then open the BNF for doxycycline, and then you need to prescribe it according to the BNF. My advice to you is that when you're practicing with us, you need to learn how to open your BNF and find what you need within 30 seconds to 45 seconds. And the main task requires about 30 to 45 seconds of BNF opening out of 8 minutes. And so we manage time like that, and we keep going. We'll teach you more when we do the workshops as well. Good. I hope everybody's been listening so far, and that we are clear. If you have any questions, I will always be open to answering those questions. And right now, I'm about to enter a next area known as the marking system to give you an idea of the marking system. Before that, if you've got questions, you have two options. You can either raise your hand or you can simply type your question inside the chat box, and I will be more than happy and inclined to help. Good. Marking system. For your marking system, I need you to know about your domains. You've got a couple domains, you've got 3 domains here. Domain 1 is mainly about data gathering, technical and assessment skills. And this will cover how you take history. Sorry, not how you take history, but your history taking. Excuse the spelling mistakes. Physical examination, practical procedures. So if you were doing an abdominal examination on a mannequin, it would count as your domain 1. If you were doing any investigations leading to a diagnosis, from everything that you've told me and from my examinations, Mrs. Smith, I suspect that the likely cause of your symptoms is hyperthyroidism, which is an overactive thyroid gland. But I do need to confirm this by doing your thyroid function tests. And so this is the investigation leading to a diagnosis, and it counts as domain 1. So what is domain 2? Domain 2 is about the diagnosis. So when I told the patient that they have hyperthyroidism, I got marks for diagnosis. And then I defined the diagnosis. I said it's due to an overactive thyroid gland. I've explained something to the patient in an effective and very clear way. I then need to continue managing the patient. And so hyperthyroidism has 2 types of management. It has the humane symptomatic management, which is probably beta blockers to keep the symptoms at bay. And it has a referral to the specialist so that the specialist can prescribe medication to reduce the production of thyroid. And so we may also explain some of the other options that if that fails, they may suggest other ways as well, such as a radioiodine drink. You need to explain what that is, and that will give you the marks. And sometimes they may suggest removing part or the entire thyroid and putting you on replacement medication. But of course, that is just the different options, but we will be able to give you more details once you go to the specialist. And so you offer them a leaflet, and these are the points that you need to cover in your formulation of a management plan. Very nice and easy. So when you were doing your data gathering, technical or assessment skills, and you were doing your clinical management skills, domain 3 is going to give you marks on how you did these things. So it covers how the candidate approached the station from the very beginning. Did you smile? Did you build rapport? Did you say hello? And then did you wait for the response of hello? And then did you say nice to meet you? And then did you say, open-ended questions first, then closed-ended questions for your focused history? It also means that when you were when you were performing your practical procedure, did you signpost when, sharp scratch coming? Did you by any chance signpost how or where in your abdominal examination you are? Okay, so I'm just going to be touching you deeper now. If you feel any pain, let me know. These are your interpersonal skills. Involving patients in their care is everything throughout. When you're suggesting a management plan, you will suggest different things and you will ask them, how do you feel about that? Using the communication tools so that you can then listen to the wishes, the expectations. So is there anything in particular that's concerning you? Are you worried about anything about your symptoms at the moment? Well, doctor, yes, could it be cancer? Cancer is one of the things that we always are on the lookout for. Can I just ask, is there any particular reason why you're worried about cancer? I'm now listening and I'm now going in. Later, when I do the diagnosis, I will tell them what I think it is and I will repeat. I know that earlier you were worried about cancer. I want you to know that it is unlikely to be cancer. And then we move forward. Finally, how you demonstrate your professionalism and understanding of ethical principles, how to say no to a patient, how to speak to close relatives of a patient without permission. Yeah, so can you tell me about my mother's scans? If you say bluntly, no, I can't, but you're not considerate, you're not kind, and you treat them like they are an alien to their relatives, this is going to cost you dearly. And so these are the kinds of things we talk about in interpersonal skills. It's about being kind, polite, understanding, and considerate to people's emotions and feelings, being sensitive when you need to say very serious things. So if you are going to tell somebody that you suspect that cancer is the likely cause, you must do it sensitively. All right, that's your marking system. I just want you guys to know how to prepare. Practice makes perfect, and it will get rid of the nerves too. We do a lot of practice during the course, and we usually make sure that we show you how it's done. And even when we are doing it, you can see that you don't have to be perfect. You just have to be safe and you have to be polite, but you also have to be able to follow your approach reasonably well. So please, it's about effective delivery of information. It doesn't come down to accents, but it does come down to ability to define something. And so that's the English you need. The English from defining a condition, the English from explaining the condition, and the different ways of doing it. Please be able to maneuver your consultation with signposting. Please build rapport and be yourself and who you have always been. You and who you are is not the problem. It's how you approach the station. Don't forget to smile. I know it can be very, very stressful and we may forget some of these things. So ask how they're doing today. Energy builds rapport too. If you come in with good energy levels, you're going to get the rapport built as well. And remember that you're a doctor. Please behave like a doctor, which is to be in control. Don't let the station be guided by the patient. It's your responsibility to know how to help the patient guide the station. We ask open-ended questions. They're in control. When they tell me the answers to my open-ended question, I now take control and I ask closed-ended questions. How can I help? I understand that you made an appointment to see us today. May I ask, how can I help? Right? Oh, doctor, yeah, I've had this headache. I'm sorry to hear that. Can you tell me more? Open-ended. Yes, doctor. For the last 3 weeks, I've got my duration. I've got the kind of pain maybe. I've had this terrible headache. It's like a band. It's really just closing down on my head. It's horrible. Oh, that does sound very horrible. So just to confirm, you said that you've had this headache for 3 weeks and it's like a band around your head. And ask the rest of the questions. It's now you who's in control. So understand your 3 domains. I'm going to quickly go through common Plab 2 station types. Again, one prescription you can almost guarantee yourself. A SIMBAN station you can guarantee yourself. You can get up to 2 combined stations, that is history with examination. 1 procedure or teaching station. 1 breaking bad news station. 1 angry patient or medical error station. An ethical type of station, such as confidentiality, unusual requests, interprofessional communication, palliative, etc. A psychiatry station can also come, and we're talking about schizophrenia, depression, insomnia. These are the ones, and suicide risk assessments as well. A pain scenario is very likely, either chest pain, back pain, headaches.